bet. Check, check, 1, 2, check. Check, 1, 2, 3, 4, 5, 4, 3, 2, 1. Check, check.
For those joining by phone, please press *6 to mute or unmute your device.
One minute. 1 minute.
For For those joining on the phone, please press star 6 to mute or unmute your device.
Hey, Josh, how are you? Good. Good.
Good morning, everyone. Good morning. My name is Nirav Shah, and I'm the director of the Maine CDC. I'd like to provide everyone an update on where things stand with respect to COVID-19 across the state. And we again begin this morning's briefing on another sad note. The Maine CDC is reporting that 2 individuals who had tested positive for COVID-19 have passed away. One was a woman in her 80s from York County, and another was also a woman in her 80s from Kennebec County. Both individuals were in the hospital at the time of their deaths. We all of us at Maine CDC offer the friends and family members of both of these individuals our deepest condolences in this time of grief. I'd like to turn next to summarizing some of the numbers of COVID-19 cases across the state. As of this morning, Maine CDC is reporting that there have been 303 individuals diagnosed with COVID-19. That represents an increase in 28 cases since yesterday. All told, there have been 57 individuals that have been hospitalized at some point during the course of their illness. Sadly, as we've noted, there have been now 5 individuals who have passed who have been diagnosed with COVID-19. There have also been 68 individuals who have recovered and have been released from isolation. Overall, Maine CDC has fielded now 3,845 consults. These are consults from healthcare providers and others across the state seeking guidance from Maine CDC epidemiologists and clinicians. I'd also like to note that there are now 3 counties across the state that have more than 10 cases, in addition to those that we have already noted. Androscoggin County, Kennebec County, and Penobscot County now have over 10 cases. I mention that because having over 10 cases is one of the 2 criteria that we use when investigating whether community transmission is occurring. The other criteria is whether 25% of the cases in any county don't have a link to another known case or a link to travel. Our investigation into those 3 counties is continuing to try to determine whether community transmission is in fact occurring there. I can also report that there have been 2 additional pediatric patients who have tested positive for COVID-19. Neither of those young people is school-aged. I'd also like to take a moment to report that there has been 1 individual who has been diagnosed with COVID-19 who spent some time at the Oxford Street shelter in the city of Portland. For several weeks now, Maine CDC, the Department of Health and Human Services, other state agencies, as well as senior officials from the city of Portland have been planning for the possibility of a case of COVID-19 in a person experiencing homelessness, in this case, someone who had spent some time at a shelter for such individuals. We are now taking the plans that we've developed and shifting over to a response phase. I will have more information about the nature of our investigation as we conduct these briefings, but based on the information that we've just received, I wanted to note that there has been 1 such individual, and again, more information will be forthcoming. I'd like to turn next to our work on testing samples at the laboratory. We are continuing to move forward with our plan to send a certain number of samples to an outside third-party commercial laboratory. These are samples that had been waiting testing at our laboratory, but because of our focus on the highest risk individuals, had not yet been tested. Maine CDC has been looking at this problem from both ends. One way is to use some of our testing capacity to shrink this number to as small as possible. So as of right now, that number stands at 600 tests. These represent individuals who were in the lowest risk category. As of right now, for individuals in the highest risk categories, that is to say, individuals who may be hospitalized, individuals who are healthcare workers, or folks from congregate settings, there is no backlog of tests at the Maine State Laboratory here in Augusta. We are also, as I've noted, we have also made an official order of a new piece of testing equipment that will help us maintain high numbers of tests. That order has been placed, and we understand from the manufacturer that it will arrive in 1 to 2 weeks. The manufacturer itself is facing a backlog of orders. After that additional machine arrives, it will take our laboratory several days to calibrate it and validate it before it can be integrated into the workflow at our lab. Again, I will keep everyone updated once the machine arrives, once that calibration process is underway, and once it's been fully integrated into our workflow. Next, I'd like to turn to the work that we are continuing to do on distributing personal protective equipment to healthcare providers and individuals who are working on the front lines across the state. Yesterday afternoon, we received a third shipment of protective equipment from the federal government. This is the shipment that I described yesterday that, among other things, contains, for example, approximately 60,000 N95 masks, as well as other pieces of personal protective equipment. That shipment arrived yesterday evening. Our team right now is conducting an inventory of that shipment, and we're merging that inventory with the shipment that we received a few days ago. Once the inventory process has been taken and that everything has been verified and accounted for, we will then begin the process of distributing those pieces of equipment to folks on the front line who very much need it. I'd like to note that we have already made one such very large distribution already, where we focused on equipping the least equipped across the state of Maine, local fire, EMS, and rescue groups, regional hospitals, etc. That shipment of PPE went effectively to your neighbors. We're going to be continuing that now and continuing our process of equipping healthcare providers who we know are on the front lines to make sure that they can stay as safe as possible. And again, we will have more information as those shipments are being prepared and as they're being distributed. I'd like very quickly just to note some of the numbers of some of the vital resources that we are tracking across the state. As of this morning, there are approximately 190 total ICU beds across the state, 90 of which are available. There are approximately 330 total ventilators across the state, of which 262 are available. And there are approximately 89 of these so-called alternative ventilators that the U.S. FDA has authorized states to utilize in times of emergency like this. We are also now asking hospitals to report even more information to us on a daily basis. As we continue our planning, we're looking for additional pieces of data. And so as of this morning, we are asking hospitals to report on a daily basis even more data to us. Last week, we asked hospitals, for example, to report the available numbers of PPE that they had on hand. Just this morning, we added additional data fields to those hospitals. We recognize that on a daily basis, collecting these pieces of data often from disparate parts of the hospital, consolidating them and reporting them to Maine CDC once or sometimes twice a day is a challenge. And so I offer my thanks to all the hospitals out there for working with Maine CDC, working with the Department of Health and Human Services to gather these data. In any type of a situation, we have to know where we're going. But in order to know where we're going, we have to know where we are right now. And having these data at our disposal helps us make that decision about how we're going to get from A to B. Yesterday, there were also some discussions about the number of individuals in the correction system. I'd just like to pause and provide a few numbers on that. All told, within individual clients at the Department of Corrections, 7 clients have been tested. 4 have been negative, and 3 are pending. The Department of Corrections is in the process of standing up a dashboard, a public-facing dashboard, where all of this information will be available and will be updated. Further questions, of course, can be directed to the department, but I just wanted to note what the numbers were and that their dashboard will be coming online very soon. Before I turn to everyone's questions, I just want to pause and share and note that at a time when we are asking everyone in the state to stay home where possible, in that context, we fully recognize that it's difficult to be engaged. It's almost as if by staying home, we're inviting more people to be disengaged, almost a social recession of sorts. And that can cause a variety of feelings. It's almost as if at a time like this, we don't really have the vocabulary to describe how we feel. For many of us, there may not even be a single word or words that describe the myriad feelings that we all have right now. For the time being, this uncertainty may be the new norm. And I fully recognize that uncertainty is unsettling. And I want to acknowledge that that feeling of uncertainty, those feelings of being unsettled, are okay. We're all feeling it. The places that you might normally have gone right now in times of unsettling to get comfort are places that we're also telling you you might not be able to go to. Church, the movies, a bar down the street, your child's sporting event, your favorite restaurant. None of those outlets that you may have otherwise gone to when you're feeling unsettled, many of those outlets may not be available to you right now. And that just adds to that feeling of being unsettled. But there are things that you can do to settle that. I ask everyone to look around them and ask what they can do to introduce some settling in their life. Call your mom. Settled. Touch base with your neighbors. Settled. See if anybody in your community needs a dozen eggs if you're running to the market. Settled. I ask everyone to look around to see what they can do to settle certain parts of their life that might otherwise feel unsettled right now. We, each of us, have a role to play, and each of us can do something to help out this greater effort, but we can also do things to introduce some calm, some order, and some settling into our lives right now. We recognize that this situation is challenging, but all together, we, each of us, can do our part to introduce that degree of settling into our lives. So with that, I'm going to turn first to some questions on the phone before we go to the room. And I'd like to turn first to Stephen Porter from York County. Stephen, go ahead.
Thank you very much. I'd like to ask for more information, if you could provide it, about the fatality in York County. I'm wondering to what extent members of the York County community should read that news as a sign that the situation is worsening or especially severe in York County. And then a second question, if I may, can you provide current data on hospitalizations, ICU bed usage, and ventilator usage among COVID-19 patients in the state?
Sure. So Steve's questions are first around additional data around the unfortunate passing of a York County resident, and then further information about current usage of hospitalization. Steve, unfortunately, for privacy reasons, we're not releasing any further details about any particular individual who passes other than their age range, gender, their county of residence, and whether they were in the hospital. But you note whether residents of York County should potentially read anything into this. And at present, community transmission is known to be occurring in York County. For me, that underscores the need for everybody across the state, and certainly folks in at least Cumberland and York County, to continue taking the preparatory steps to keep themselves and their families safe. Unfortunately, COVID-19, based on the data we've seen in other parts of the world, other parts of the country, COVID-19 does carry a fatality rate with it. And in individuals who are older and in individuals who might have a chronic health condition, that fatality rate is even higher than it is in the general population. That's sad and it's unsettling. And unfortunately, in this particular instance, one such individual did succumb. Now, your other question is about current hospitalization resources. We are actually rethinking, we're working on our data systems right now to start focusing on being able to provide information on current hospitalization utilization numbers, daily hospitalization rates, number of patients on ventilators, et cetera. We're working with the hospitals to get that information on a very timely basis and match it up with the cases that we've got. That's one of our big projects going forward. So our epidemiology team is working on that exact project right now. Hopefully going forward, I'll be able to have a better glimpse into that on a daily basis. I don't have it here today with me, but that's where we're going in terms of being able to get a better snapshot in time of our epidemiology data. So thanks for that question, Steve. Going next to Steve Missler. Steve, go ahead.
Thanks for taking the question. Can you hear me okay?
Yes, I can. Go ahead.
Great. I was wondering, do you have any data on confirmed cases from congregate settings? And you talked at length yesterday about congregate settings. I'm just wondering if you have could give us a snapshot of how many cases from congregate settings we are currently dealing with.
Okay. So Steve Missler's question is around cases in congregate settings. Cases in congregate settings are a very high priority for us. They are, again, one of our areas of focus for laboratory testing. Congregate settings pose unique challenges. One, we know that transmission can occur more frequently because of the close proximity. Something that I think Kevin Miller and I talked about several weeks ago is sleeping arrangements and things of that nature. So congregate settings are a concern for us. And so, Steve, right now, there are all told in the state 13 cases of COVID-19 associated with congregate settings. 12 of those are the cases that I mentioned yesterday in various healthcare-related congregate settings. And then one is the additional one from Oxford Street of an individual experiencing homelessness that I mentioned a while ago. Again, congregate settings are a very high concern for us. We've been working on planning for such settings for quite some time. In concert with city officials, we're now shifting into the response. Does that answer your question, Steve?
It does. And if I may, with a follow on
Sure.
a separate matter, if you don't mind.
Go ahead.
One, can you just address mortality rates of people who need a ventilator? And I ask that because there has been some research out of China suggesting that the mortality rate is very high, but it
Yes.
was really seemed that, like, to me, it seemed as if it were a very small sample, and maybe you have access to research that's a little more sweeping than what I saw.
Great. So Steve's question is about mortality rates, particularly in acutely ill individuals, perhaps those that require mechanical ventilation or a ventilator. And Steve, as you know, the mortality rate for individuals, the less well they are, the higher the mortality rate is. Sadly, for individuals in ICUs, there are different studies. And so I'm not going to quote any particular one, but the range of mortality in those individuals is quite high, well into the double digits. And that's quite unfortunate. On the other side, however, the percentage of individuals overall who require not just hospitalization, but critical care unit hospitalization is smaller. And again, the data that I'm referring to are all publicly available data. Much of it is published in the CDC's journal as well as in top journals like the New England Journal of Medicine and JAMA. And so those are the same data that I'm looking at. I can try to post or try to get you some of the studies that have looked at that aggregate mortality data. But overall, a small percentage of individuals require mechanical ventilation or ventilators. A small percentage of individuals require intensive care. But those who do find themselves in intensive care, quite sadly, their mortality rates are high. And I can provide some of those papers for better clarity around that, so I'm not providing approximate numbers. I'm going to turn back to the room, and we'll start with Kevin.
Do you have an update on the number of healthcare workers that have been affected?
The number of healthcare workers still stands at yesterday's number, which I believe was 43 healthcare workers. So since yesterday, there have been no new healthcare workers identified.
Do you have any additional breakdown of where those are? Are they?
I don't have that breakdown with me right now. We can try to furnish that. I'm not sure if I think we could probably furnish that. I have the breakdown of where individuals have been hospitalized, but not the healthcare workers themselves. So we can try to get better insight into that. We are aware of, for example, 2 individuals at a hospital in the Mid-Coast region who have been noted as having COVID-19. The last time I took a look at the data, it was quite dispersed across the state, as well as quite dispersed within the healthcare community. Frontline workers, physicians, et cetera. So quite dispersed. So, yep.
There's a report in the Washington Post last night that the U.S. CDC is considering recommending the public wear masks anytime they go out into the public. Any thoughts on that and recommendations for people here in Maine?
We're aware that those discussions, the question is about potential recommendation from U.S. CDC for more widespread use of masks. I want to stress the word potential. The recommendation hasn't been finalized. State health officials, such as myself, have not been briefed on it. I'm not sure if it's been approved by the CDC director himself. I know that it's something that's under discussion. And so until any official recommendation is made, I can't really evaluate what it does, what it would say, what it might mean for the people of Maine. Based on the last data that I've seen, again, the use of masks is really something that right now we're focused on providing to healthcare workers, but we are, of course, in constant multiple times per day conversations with U.S. CDC. If those recommendations, if that thinking that they're doing becomes finalized, we'll certainly make sure everyone's aware. So, yep, Caitlin?
Can you give us a little bit more details about the third-party group that you were looking to send these samples to? And I guess, like, why, if there's, like, a backlog with them, why are you considering sending those samples to them? Is it like there are only so many places that can, like, do the kind of testing that you need? Like, can you give us more details on that?
So Caitlin's question is on the rationale for sending some of these lowest, some of the samples from the lowest risk individuals to a third-party lab. And it's a good question. I'm glad you raised it because we've had very robust discussions internally about whether we should just use our laboratory to clear out this backlog. And there are a couple of reasons. The first is we continue to be concerned about the ongoing availability of these chemicals to do the test, the reagents. And for that reason, we also know that the number of cases of COVID-19 in Maine will increase. We know that it will spread both geographically and in number. So one of the things that we are trying to do is ensure that our state laboratory has enough excess capacity so that if a healthcare worker, for example, were exposed or a critically ill patient comes in the hospital, we have enough excess capacity at our lab to turn around a result ASAP. The second piece that we also always have to be prepared about anytime we're doing any type of emergency response is having a backup plan. Unfortunately, COVID-19 is now starting to affect healthcare workers across the state. Some of those healthcare workers may sadly be individuals that are at our laboratory. We have to have a plan in place for that. Our job when we do these plans is not to be alarmist, but it's to worry in advance. And one of the other reasons that we're pursuing this strategy is not just to ensure that our laboratory always has resources on hand for critically ill patients, but also to exercise a backup plan so that if our laboratory staff sadly were to fall ill, we have a way to continue continuity of operations. So.
Can you tell us where you're considering sending those
Sure.
parties to?
We're using a commercial laboratory called LabCorp.
In like a different state? Or?
So LabCorp, their main COVID, so my information here is 5 or 6 days old, so this may have changed. And so I would refer you to LabCorp on the latest. But as I was briefed several days ago, their COVID-19 testing is occurring in North Carolina, but they were rapidly bringing it on in other testing sites. So my information there is several days old. I would refer you to LabCorp. We are going to be sending the samples to a depot, and then they will be distributing the samples there to whichever of their laboratories they designate. So, yep, Brad?
What can you say about the new preschoolers? Are they in the same family? And what about the first two children? Have they been healed from this?
I didn't note that they're not. I don't know if they're preschoolers or not. Just to be, they're not school aged, and so at this time we're not releasing any further data on them. To be totally candid with you, as far as the first two, I will check on what their clinical status is, and we'll be able to get back to you. So. Yes.
So Governor Mills' executive order on non-essential businesses, looks like it ended about April 8th, and that's close to a week. Has there been any conversation between you and Mills about maybe further extending that deadline, and what's your recommendation with that going forward?
You know, this is so the question is around the ending of Governor Mills' requirement that non-essential businesses close, as well as other recommendations for essential businesses to limit the density of individuals. We are continuing to work with the governor's office, the commissioner's office on a daily basis to evaluate the data. So no final determination has been made. All options continue to be on the table. We are, as you've certainly seen in covering the situation and tuning in, the situation changes hour by hour, day by day. So we can't predict what the world may look like at that time, but we are in very, very close contact with the governor's office, with the commissioner's office, as we continue to analyze the data. So I'm going to go back to the phone and turn next to Steve Betts at the Knox Courier-Gazette. Steve, go ahead.
Yes, hi, Dr. Shaw. Thank you. When the personal protection equipment was distributed to hospitals and emergency medical staffs across the state, was there any consideration given to the increase in seasonal residents that arrive, that these areas may need more of those equipment?
So Steve's question is around how we distributed the first cache of protective equipment and whether we took into account changes in population. And Steve, you know, what our strategy in making that first wave of distributions was to equip the least equipped, our neighbors across the state who often, in many cases, sometimes on a volunteer basis, are going out there to care for folks. And so irrespective of whether they were in an area where there was a potential increase of visitors, increase of seasonal residents, what we looked for was who was the least equipped. And that's where we started. And that so it's not so much a function of who might be coming in, but it was more a function of who did we need to bring up to some baseline first. And that was our primary objective in making that first wave of distribution. So,
Can I just ask a real quick follow-up?
sure thing.
Has there been any thought given of a follow-up on the number of cases per county, regardless of where the people are from?
Right. So Steve's question again is about individuals who may not be residents of the state of Maine, but who still may be here for right now. And again, what we know is that community transmission is occurring in many places in the state. It will continue to occur across the state. Our view is that no matter where you are in the state of Maine, even if your county has not yet recorded a case, keep continuing to prepare. No one should be waiting to see whether an out-of-state resident happens to be in their county before they decide to continue or start taking action to prepare. What we know based on the spread of COVID-19 across the Northeast, across northern New England, is that it is almost inevitable that it will spread to every quarter of the state. Whether that happens to be from out-of-state residents or in-state residents should not change the approach that every single family should be taking now and that I urge them to continue to be taking. I'm going to turn back to the room, and then we'll pick up the last two folks on the line. Yep.
We've had some questions about daycares. Can you talk about safety precautions that daycares can be taking, and then also if those will always remain as essential businesses?
So the question here is around daycares and safety precautions for daycares and their status right now as essential. For some of the more detailed pieces, I would probably refer you to the Office of Child and Family Services, to Director Todd Landry, but he and I are in close contact. His office is part of our briefings every single morning, so he's very well aware of where things stand, and his office has been a great partner to us. Director Landry's team has put out different and several pieces of advice and guidance to daycare centers, including how they should be taking steps with their own staff to stay safe. Certainly, as guidelines are changing at the national level, as you noted with masks, we'll continue to communicate those things to them if those would affect how daycare centers change. Now, as to the determination of essential, that's probably really probably a better question for Director Landry. That continues to be my view, but I want to make sure I get his view on that too. Going to take back to Kevin, and then we'll go to the phone.
I think a lot of us continue to hear people asking questions about stay-at-home orders and why Maine has not followed some of the other states. I think last night, as of last night, about 29 other states had stay-at-home orders. Can you talk just a little bit more about that and what goes into that decision about whether to issue a statewide stay-at-home versus allowing cities and towns to make that decision?
Right. So Kevin's question is about stay-at-home orders, and what is our thinking around that? What's our analysis with respect to stay-at-home orders? I want to say at the top again, Kevin, all options continue to be on the table. We're continuing to look at stay-at-home orders as well as many of the other things that have been discussed. So no option is off the table. But when we think about stay-at-home orders at this stage, we have to evaluate them against the orders that are already in place. For example, Dustin's question, I'm kidding, Joe's question with respect to essential businesses. Governor Mills has already recommended that essential businesses disperse and provide low density, that non-essential businesses will close. What we know about disease transmission is that it occurs in places of congregation. At this point, right now, it's those non-essential businesses as well as essential businesses with high density. Someone staying home by themselves or with one or two family members doesn't pose any threat. What I think is relevant, as well as an analytic point, is ways in which the state of Maine may differ from other highly populated, high-density areas. Even within the state, we see dramatically different population densities, Portland being different from Knox County. And when you have at baseline lower population density, the value of the stay-at-home order, we have to think about that. In a place like Portland or let alone Manhattan, going outside, walking down the street where there might be 70,000 people in a square mile, or even a few thousand people in a square mile in Portland, is a much different risk profile than somewhere else in Maine where there might be 30 people in an entire square mile. So we have to keep those epidemiological considerations in mind. We also have to keep compliance in mind. At a certain point, we've got to take into account compliance and enforcement with any such order. And so those are all the considerations that we think about. We're always evaluating them, but I want to be straight with everybody into how we are thinking about those orders. And I would ask everyone to, one, think about what's already in place, which is restrictions on congregation at business places. And then two, think about the population dynamics and how those differ from other more densely populated states. I'm going to go back to the phone, and then Brad will go to you next. Amy Brown from WERU, please go ahead.
Thank you, Dr. Shah. I have two questions, if I may. The first being, with the governor's executive order expiring today at midnight, are we expecting an announcement sometime today about an extension on that?
Okay, I'll take that one. I think that one, Amy, would be better. I'll refer that to the governor's office, and we'll make sure that if you could either check in with them or alternately, we'll have someone get in touch with you on that.
Okay, great, thank you. And there are 6 people on the list of positive tests that are listed as being in unknown counties. Can you explain how that works?
Great. So Amy's question is about what is meant when we say a county is unknown on our website. And for that, Amy, what I'll do for a second is, again, kind of pull back the curtain on how we receive results and then what we do with them. And what happens now is that overnight, the commercial laboratories, as well as our own laboratory, through an electronic laboratory reporting system, send us updates on who they've tested. They send us an update that they have tested certain individuals who have been positive. And what we get in that report is usually a name and a date of birth. We then have to reach out, if possible, to the healthcare provider to get more information about that patient, namely a phone number. We then have to contact that patient, and touch base with them to learn about where they live, what their county of residence is, and then go into all the questions we ask them. Where have you been in the past 2 weeks? Name every single person you've had a close contact with, etc. Not everyone always picks up their phone when they see an unknown number. And so, or people may not immediately call us back. And so when we list a county as unknown, all it means is that we have not yet touched base with that person, and our disease detectives are trying every single way we can to do so. So it's not that it is unknown in the sense that nobody knows. It's unknown in the sense that our disease detectives are in the process of reaching out to them. Going to go back to the room, back to Brad.
2 quick questions. One is, you must think that social distancing is working in Maine, because we would probably have a lot more cases now if we weren't doing this, and that's it for now.
Okay, so Brad's question is around social distancing. And Brad, there are some informal, unvetted, non-peer-reviewed sources of data that folks have offered. They're publicly available, that folks have looked at to try to gauge to what extent social distancing is occurring in Maine. I am not endorsing any of these modes of analysis. They are out there, but some of them utilize cell phone tracking data by the cell phone companies themselves, not by Maine CDC, but the cell phone companies themselves have been reporting, for example, to what extent are people straying from their home address that they have. And in that respect, it does appear that social distancing has been happening in Maine. Other data look at the way in which traffic patterns have changed. And there again, early signs are that social distancing has been happening in Maine. I want to take a second to thank and commend everybody in the state for abiding by these public health recommendations to introduce what It's called social distancing, but is really physical distancing, to introduce that physical space. We know from other states, from other countries, as well as from historical experience, that this physical distancing is the surest way to disrupt the natural transmission of the virus. There's evidence anecdotally, as well as from some of these other sources, that it's occurring, and I thank everyone for following these recommendations. I'm going to go back to the phone, and then Caitlin will turn to you. Don Kerrigan. Don, over to you, sir.
Yes, good morning, doctor. Thank you very much. A question about hospitals and then a question about reporting, if I can, please. First, the hospitals. What is happening inside these hospitals now? We see from New York and those places got the crisis there. How are the hospitals dealing with these cases of COVID, particularly the people who are hospitalized? What's actually happened? Are these just severe, I shouldn't say, are these all severe pneumonia cases that they're handling?
So Don's first question is around the hospitalized individuals. As I mentioned, right now there have been approximately 57 individuals who at some point during the course of their illness have had to be hospitalized. And Don, as your question notes, the range of severity, even within hospitalization, is significant. Some fraction of the cases in Maine have had to be admitted, but not into critical care. Others have been in critical care. We'll have better numbers on what that looks like very soon. But Don, what I can also say is that having spoken with clinicians, critical care physicians across the state, it's a challenge. They are, of course, facing challenges on some of the things that we're aware of, like the availability of protective equipment. That's something we're hoping to help them with as much as we can, recognizing that it's a valuable but essential resource. But I also think we should pause to recognize the emotional toll that caring for critically ill patients, especially high numbers of critically ill patients, places on all members of the hospital community, whether that's physicians, nursing staff, the EMS professionals that transport them there. The emotional toll is in some cases, talking to friends of mine, can be just as great as any other piece of this. So Don, we'll get you more and better data about some of the specifics, but I think we can all say that hospitals are facing significant challenges right now. We have been and continue to work with them on their planning and on their response to help them be equipped with as much as they need, but we fully recognize the challenge this takes. Don, I know you had a second question, so back over to you.
I did. Thank you very much, Doctor. The second question is about reporting, and this question of out-of-state residents who are here and ill. A couple different pieces of that. Do we yet know how many of those people there are in Maine, out-of-state residents who are here and ill, who we have essentially handed off, at least the reporting of them, to their home states? If those people, some of them are hospitalized, does the hospital count include them? If any of them, God forbid, pass away, will that count include those residents?
Great. So Don's question is how we again manage out-of-state residents. And Don, if an out-of-state resident were to be in Maine and pass away, for example, that passing would be recorded by the state in which the individual is a permanent resident, not by the state of Maine CDC. We're not aware of any such individuals as at this time who have been out-of-state residents who have passed away. But again, if that were to happen, that passing would be recorded on their state of permanent residence rather than on the Maine CDC numbers. So I'm going to turn back to Caitlin.
Yes. Two short questions. Can you talk about whether these homemade masks that people are working on, do they provide any actual health value beyond providing additional cover over a different mask? And my second point is, I know hospitals waste a lot. A lot of times they throw away things that just end up being expired. Has the CDC reached out and giving any guidance to hospitals about maybe not throwing away some of that equipment, depending on what it is and how useful it could be?
So Caitlin, I'm going to take those in reverse order. Your first question is around fundamentally about expired products and whether those should be utilized versus tossed. And there is actually guidance from the US CDC on the evaluation and potential use of PPE that may be expired. And and we've communicated that guidance to hospitals several weeks ago, actually, when it first came out. So we have a standing call with hospitals twice a week, if I remember correctly. And one of the people that leads that call is our head of infection control and hospital-associated outbreaks, and she is on each of those calls. And when that first US CDC guidance came out, we sent it and then discussed it with hospitals. And the guidance talks about the fact that there are certain integrity checks that hospitals can undertake on pieces of PPE that may, per the expiration date on the box, may be expired, but that still might be good. So checking the elastic bands. If the elastic bands are strong and intact, it's likely that the mask itself is fine. So the guidance walks through those scenarios and advises hospitals on how to conserve that PPE rather than tossing it out. So we've communicated that to them, and we're urging hospitals to heed that guidance. Your first question was around handmade masks. And there are two different ways to think about handmade masks. The first is for members of the general public, and the second is for healthcare providers. Let me say at the top that it's really awe-inspiring and warming that so many different groups across the state of Maine have offered assistance in sewing these hand-sewn masks. Everyone from school groups to sewing circles has offered their assistance. And there are actually guidelines on how to sew these masks. So the masks are not as good as an N95. And so with respect to the two groups, the first is the general public. There is maybe a value, you would think, in having a hand-sewn mask on your face. But the consideration that I urge everyone is that while it might be something to have on your face, a lot of people, based on observational studies, actually touch their face more because they're fidgeting with and trying to adjust the mask. Those two things have to be balanced out. The other category is with respect to healthcare workers. And there, I think our strong preference would be that healthcare workers use a proper surgical mask or an N95 mask rather than a hand-sewn mask. I think we've got time for one last question in the room. Yep, Joe?
Your age demographics, it's looking like 78% of these cases are with people above the age of 40. And looking at the recoveries and how everything's going, do you see, is there any sort of relevance to, younger kids or younger individuals recovering faster as opposed to older?
Could you tell me a little bit more about your question? I want to make sure I answer it 100% accurately.
78% of cases are people of the age of 40 or above, and looking in relevance to the amount of recoveries, have you seen any sort of corresponding data of the recovery?
Got it. So Joe's question is about sort of linking up the number of individuals who have been ill and their age group, and whether that corresponds with similar numbers for the people who have recovered, and whether we're sort of seeing parity between those. Is that an accurate way to, okay. So that analysis is actually underway by our EPI team right now. In the beginning or in the middle phases of an outbreak, our focus is first and foremost on those who are ill. And then now that we've got a sizable number of folks who have recovered, we then look to get more information and understanding of those folks, namely their age breakdowns. What we've seen so far is that the categorization, the age breakdown of those who have recovered largely matches what it has been nationally, which is that younger folks without pre-existing health conditions, those are the folks that are coming out of recovery fastest. Folks who are older, those who do have chronic medical conditions are coming out of recovery slower. One of the things that we look for in recovery is not just the numbers, but the rate of recovery. That is to say, how many days elapse between when you first started showing symptoms until when you've met the US CDC's criteria for being classified as recovered. That's actually the analysis that we're working on right now, because as your question suggests, we hope that what it shows is that for folks who are younger, folks who have fewer health conditions, their rate of recovery is faster than folks who are older. The reason that's important is it means that those folks can get back out into the community sooner and may not need to be at home as long. But I also would be remiss if I didn't underscore the fact that there are data from the US CDC that show that a rather high percentage of individuals who have to be hospitalized are in this younger age group. The data suggests that based on a series of about 500 people who had to be hospitalized, a very high percentage, almost half of them, were between the ages of around 20 to 50. That does not mean that everyone between the ages of 20 to 50 does not mean that half of them will be hospitalized. But if you start with the people who had to be hospitalized and look at their age category, a very high percentage of them were on the younger side. So that's concerning. What it tells me is that everybody needs to take precautions, not just folks who are older, not just folks who have chronic health conditions. So with that, thank you all for joining. We will have additional information and updates tomorrow. But as I close, I again just want to underscore the fact that these are unsettling times. And that unsettlement, that feeling of being unsettled, is driven by the uncertainty we're all feeling. In my own household, we don't even really quite have the right word to describe it, and that's okay. But I do ask everyone to take steps to introduce some of that settling into your lives. Call your mother. She's waiting to hear from you. So with that, we'll talk to everyone tomorrow.